Now my privilege to introduce our first speaker, HOAG'S Senior Vice President and Chief Hospital Operations Officer, Marcy Brown. Marcy is responsible for hospital operations at both Hoag Hospital Newport Beach and Hoag Hospital Irvine. She oversees Hoag's Chief Nursing Officer as well as lab, pathology, radiology, pastoral care, community medicine, and the Hoag Urgent Care Network. She has been instrumental in leading Hoag through the COVID-19 pandemic, working in lockstep with the CDC and infection prevention to implement protocols and procedures. As a result, she has successfully delivered the best in care for the community, ensured the safety of frontline workers, provided robust treatment options for positive patients, and positioned Hoag as a leader in Orange County during this challenging time. I want to thank Marcy for taking the time out of her busy schedule to being here with us today. We're lucky to have her. Welcome, Marcy.
Thank you so much, Raphael, and thank you so much to you and Shady Canyon for hosting us this afternoon in this webcast or Zoom meeting. We really appreciate the opportunity. And I just have to mention that all of those accolades, those wonderful accolades that you gave me credit for, there's a whole village standing behind me, a whole team of experts and many, many nurses and physicians that have helped navigate through this pandemic. And I'm so grateful to them, so grateful to be a part of the Hoag team. Before we launch into our presentation this afternoon, I just want to give the group a quick update on our Hoag Irvine expansion plans. We are still forging ahead with a very, very exciting expansion that we're going to be launching with the first phase, which involves a parking structure here in the next few months. We're going to be breaking ground on that on the Hoag Irvine campus. And then shortly after that, we're closing the deal on the land acquisition. The purchase is in escrow, and we're very excited about that. That should be completed in the spring. And then we're working through the agency approvals for all of the reviewing the entitlements and forging ahead with the OSHPD geotechnical analysis. And so we're very, very excited. When we're done within 5 years, we will have built 2 dedicated specialty hospitals on the Hoag Irvine campus that we will be so proud to deliver to the community. It will be a dedicated cancer specialty hospital, as well as digestive disease institute, and also a women's hospital. So very, very exciting times for Irvine and the community. We've got an action-packed afternoon here. We plan on going through Hoag's approach to COVID now and in the future. In addition to that, the community impact, what you can do, what your part is in this pandemic and fighting it, ways you can help, and then we're looking forward to Q&A at the end of our presentation. So Hoag's approach to COVID-19, I'm so grateful for the team of trained infection prevention experts. In addition to that, our clinical preparedness team. This has really been Hoag's superpower the past 4 to 5 months. I'm so grateful. We're going to talk a little bit about that preparedness work and how we're putting together that playbook as we head into the fall. In addition to that, we're going to talk about our testing capabilities and what our experience has been so far. And then I'm going to turn it over to my colleague, Dr. Brant-Zawadzki, Dr. BZ, as we all know him, to talk about those leading edge treatments. One of our key physician executive leaders in infection prevention in our COVID-19 task force, if you will, has been Dr. Phil Robinson. He is our medical director of infection prevention. He heads up our hospital epidemiology and antimicrobial stewardship program for both Hoag Hospital and Hoag Orthopedic Institute. So fortunate that he's leading our team. I'll tell you what, something about Phil, he has just been the calm in the storm. He always lets the science lead our decision making, and I respect him so much for that. And he continues to be that stable force for our community. He also has critical relationships with not only the Orange County Healthcare Agency, but the CDC as well. And in those early days, that was really critical. In addition to Dr. Robinson, Dr. Grace Lazinski is our Chief Quality Officer, and she has also been boots on the ground every day, helping to lead our command center and our task force. And Some of you might recognize her as she is a Shady Canyon resident. So your community is fortunate to have Grace and her family there as well. In addition to Dr. Lazinski and Dr. Robinson, Dr. Michael Brant-Zawadzki, who has joined us today, is our Senior Physician Executive at HOAG. He's our executive leader of the HOAG Center for Research and Education, which has been so crucial for us in these COVID fighting days. In addition to that, he's our Ron and Sandi Simon Executive Medical Director, Endowed Chair, and runs our Pickup Family Neurosciences Institute. And also Dr. Mike Hurwitz. He is our Chief of Staff, and he, along with a team of almost 2,000 physicians, has been making sure that our medical staff has been positioned for success. As I mentioned, in the early planning phases, we really let science lead our decisions. And you can't imagine what it was like on the evening of January 24th. It's not very often I get a text message for a mandatory conference call at 10:30 at night, but that happened on January 24th. It was the call that gave me a heads up that we were about to receive the first known diagnosis of COVID-19 in the state was headed to HOAG Irvine. We did have that conference call, and the next morning we took that admission of that first patient, and wow, was that a learning experience for all of us. During those days, Dr. Phil Robinson led the care of this individual and did an outstanding job. I would say on about day 3 or 4, we got a call from the CDPH saying they were headed over to HOAG Irvine. They wanted to begin to survey the hospital and survey all the staff and take a look into our practices and how we were caring for this patient. I was so proud. It was about an 8 to 10 hour survey, and the head surveyor pulled me aside out of the boardroom and said, "Marcy, I want to tell you, in 3 decades of doing this work, I have never seen an organization positioned like yours to take care of COVID-19. From your emergency room staff to your housekeeping staff, the dietary staff, they have got this hardwired. Their practices when it comes to PPE and protecting your families, your visitors, your patients, and each other, they were so proud. And it just put me in a position as COO to say, hey team, we've got this, we've trained for this, we're ready for this. And so let's show the community how we can take care of COVID-19, which I'm so grateful for. So if there's one thing that has really taken up a lot of resources and attention, and rightfully so, it has been testing in our community. And really for those of you, I mean, you can't open a newspaper or watch the news without hearing about testing and either the shortage of test kits or the shortage of rapid platforms. And then there's all these different companies coming up with the silver bullet, if you will. They've got the magic test. And so we have always stuck to what HOAG and the HOAG brand stands for, which is we will never compromise quality. We will never compromise the results of the tests. And so there have been tests out there that have been tempting, if you will, because they provide, rapid, meaning within an hour results. But what we have found is that if you want to be able to act on the results of the tests, some of the platforms that HOAG has been using and is using today are the ones that provide that 98% reliability every time. We are having some challenges. You can see that over 22,000 tests have been performed. The majority are in our urgent care setting. The rapid tests that we have in the hospital, we save those for our emergency room patients. As you can imagine, those patients need to be dispositioned in a very quick way. And so we want to know, are they positive? Do they need to be admitted to the hospital? Can they be discharged to be quarantined at home and take care of their symptoms at home? So we're saving those precious rapid resources for in-hospital testing. We still, to this day, are only testing symptomatic patients. So what I phrase the worried well, just wanting to be tested because they're curious, we don't do that at home. We're saving the testing resources for only those patients that are symptomatic. We are, however, testing our preoperative patients, so patients that are scheduled for surgery and need the operative room team and the nurses caring for the patient need to know whether or not they're COVID positive, because remember, some patients don't even realize they have the virus. And we have had a handful of patients come in for a surgical procedure, not realizing they're COVID positive. And so we are using some tests on those individuals as well. So the majority, I just want to say again, the majority of patients that are testing positive for COVID through our urgent cares and even some of the hospital are not needing to be hospitalized. It's only the sickest folks who need their symptoms managed in an acute care setting that are being admitted to HOAG. So before I turn the floor over and announce Dr. Beasy and his slides that he's going to be presenting, I just want to talk about an inspirational story. What's been really, for me, been inspiring is seeing the innovation and the great kind of out-of-the-box thinking, if you will, of our team at HOAG. And this story is one of a new mom who came to HOAG to give birth. She was in labor, and we performed one of those rapid tests on her, which we do for our moms giving birth at HOAG, and her test came back positive. And if you can imagine just the thought of not being able to be separated from your child at birth was so stressful for her and her partner, her husband. And so once we knew she was positive, we knew that she wouldn't be able to be with her baby, nor could her husband, because her husband obviously had been with her up to the point when she was in labor. So when she gave birth, we had to separate the baby from the parents, but the nurses put the baby in the NICU nursery, which through our philanthropic funding years ago, we had purchased NICU cameras, and these cameras are literally an eagle's eye on the baby at all times. And through your cell phone or through your laptop, we give access to the parents to be able to view the baby. So that was really remarkable that they were able to stay connected to the baby using the NICU cameras. But then it was really the creativity of the nurses and the HOAG physicians that were the impetus of this. And they said, can we find a relative, a surrogate that could step in for mom and dad and be in the NICU nursery and be with the baby and take over that role for the next 10 days while the parents were quarantined. And so we did that. They chose an aunt, and the aunt was the surrogate parent, if you will, for that baby in the nursery. And that sense of security that it gave the parents, that they had a family member to be there and be with the baby, was fantastic. And then after a week, the aunt said, okay, it's tag team time. Who can we have come in here and take over? And so we screened grandma, and then grandma got to take over and be with that newborn baby. And so to take a situation that was so stressful for those new parents, and through the ingenious work of our nursing team to get the baby in the arms of a relative and grandma and aunt was just fantastic. So I thought I would share that. And now I'm going to turn it over to Dr. Michael Brant-Zawadzki, who actually recruited me to HOAG over 20 years ago now. He's a dear friend and colleague, and in addition to his roles as a senior executive at HOAG, he also serves as the adjunct clinical professor in neuroradiology at Stanford University. And Dr. Beasy lectures nationally and internationally and consults in the fields of imaging, pharmaceutical, informatics, and healthcare policy. And so thank you so much, Dr. Beasy, for being with us this afternoon, and I'm going to have you take it from here.
Well, thank you so much, Marcy, and thank you, Raphael and Shady Canyon for hosting us. We've been to your facility, we've had some events held there. A lovely place to live. I just want to remind Raphael that in addition to all of the things that he mentioned that Marcy oversees, he neglected to mention that she also oversees me and I'm her toughest challenge. I will tell you that. And I'm sure she'll second that emotion. She's a hard to follow. She's hard to keep up with. I'm so proud of what the job that she has done in leading our team. I'm going to speak to you. I have privileged to have a number of assignments at HOAG. The current assignment, the prism through which I will be discussing the following handful of slides with you, is my role as the executive leader for our HOAG Center for Research and Education. And so let me take you through some numbers that are going to be a little bit tough, but I'll try to make them as easy and as palatable as possible. First, these numbers of cumulative positive tests by county. The top blue line is Los Angeles. The lower lines are Orange County, San Diego, and Santa Clara, Riverside as well. Notice the discrepancy is because Los Angeles is 10 million people, Orange County is a third of that, actually less than a third, and Santa Clara County is only 2/3 of Orange County. So when you're looking at these graphs, total number of cases being overwhelmed by these cases, remember when you do comparisons, for instance, today in the news, we were told that California surpassed New York in the number of cases. Well, remember, California is twice the size of New York population-wise. So equaling New York, yet having twice as many people is not as scary as it first sounds. I'm going to take you through these numbers from left-hand side over to the graph eventually. So cumulative cases in Orange County, almost 31,000. Daily positive cases received in the labs, 990 cases. That is not the same as new infections. We can test positive for up to 57 days after being infected. So if we happen to have been infected 30 days ago, but only get our test today because we're having a surgical procedure, for instance, and test positive, that is not a new infection. That is, in fact, an infection that occurred 30 days ago, but only comes to light now because, like I said, we can test positive for up to 57 days, and yet we're not infectious beyond day 8. So again, important to interpret these numbers in context. Sometimes the media doesn't have the time to provide that context. Cumulative cumulative deaths to date, that is a hard number. It's hard to fake that number. 513 deaths for a county of 3.1 million people. Just to normalize, against context-wise, just for yourselves, look up how many people die every day as a background number, and you'll see that 513 adds to that background number, but certainly does not exceed it. Deaths reported today, same comment. Going down to the most important number, I'll skip the two on the left on the bottom row. The most important number we want to concentrate on as a healthcare team, as a healthcare system, is cases currently hospitalized. The whole idea of flattening the curve wasn't to make the virus disappear, because the virus is going to do its thing, but it was to not overwhelm the hospital system. So as of yesterday, today it's actually 699 patients in our Orange County hospitals. Divide that by the 26 hospitals. It averages to about 27 patients in each hospital. And that's what we have at Newport today, 27, just as a normalizing number. So that 700, if you take that 700, today's hospitalized patients are 699, we'll spread that over 6,600 hospital beds in Orange County. We only have about 10 to 11% of all of the beds in Orange County occupied by COVID patients. So you may be hearing dire predictions in the news about hospitals getting worried about being overwhelmed. That has happened in rare cases. And El Centro, and that's why we got patients from El Centro Hospital. They were overwhelmed down there. We have not yet seen that in Orange County or even in LA County. The majority of patients who are hospitalized do not require the ICU. 234 of the 700 in Orange County that are hospitalized are in the ICU. Same comments. It is nowhere near reaching the capacity of all of the ICU beds available in Orange County. Finally, let's move to the graph on the right. You'll see the number of daily cases. And again, remind you, these are not new infections. These are new positive tests. And the yellow line is a 7-day moving average. So factor in the right-hand side bars, which aren't yet part of that 7-day moving average, to the downward trend that the yellow line shows as a 7-day moving average. And you'll see that we're breathing a little bit easier, that the totally expected surge in positive cases, which does include new infections, with Memorial Day and reopening, we totally expected this curve to do what it's doing. And the hope that we're seeing now is that the virus doing its thing with reopening is receding, much like in New York City, which has basically come down to that left-hand baseline of the curve that we saw in early March. New York City has come down to that baseline. I am hoping that we will do so over the next 4 to 6 weeks. I actually have a case of beer bet on that, and with someone who's a non-believer in that possibility. But I'm an optimist. What can I say? So anyway, I want to give you some reassurance that only helps balance, I think, the numbers that the media focuses on, because as you know, in the media business, if it bleeds, it leads. So focusing on the good side is sometimes not as newsworthy as focusing on a balanced approach and a contextual approach to these numbers. Now, switching from Orange County, I want to give you the HOAG'S combined experience, Irvine Hospital and Newport Beach. We've seen almost 850 cases in our emergency room with coming to us as a hospital. We've only had to admit, as Marcy mentioned, less than half of those, 379. And only 67 of those, approximately 15% of the patients admitted to the hospital actually had to go to the intensive care unit. Very unfortunately, we have lost 20 patients. That is not a big number if you, again, compare it to the background of folks who expire in the hospital on a routine basis. People unfortunately die from all sorts of conditions. These 20 added to those conditions, but it's a small percentage of additional deaths that we normally expect to see over the course of a 4-month period of time. Many of these cases that did unfortunately pass away came to us from nursing homes. We'll talk about that in a second. And disproportionately so, of the 20 that died, the folks that came up from El Centro by state mandate to us, distributing cases in many hospitals in Southern California, the disproportionate number of the 20 that passed away came from these 11 patients that were transferred to us already in very advanced, serious condition, and so were difficult to salvage. The good news is that many of our patients can be discharged to home, and some of them require a short stay in the Gary Fudge or the Fudge Family Acute Rehab unit, which we have at HOAG, to help rehabilitate them from the debilitated state that the infection left them in. And yet, very few need to go to a skilled nursing facility. We make sure that they're safe to go and no longer infectious to go to these skilled nurse facilities. And there's a small number of other dispositions. The hospice patients are typically patients with advanced cancer who also happen to be tested positive while they're here for their care. Next, I'll take you on those pie charts to document what Marcy already well knows. Men are the weaker sex. And so we men are disproportionately affected by COVID. 54% versus 46% of HOAG'S admissions reflect the national numbers, men being more affected. And if you look at just the admissions by gender, even more men disproportionately to just the background case rate, more men get admitted, meaning men are disproportionately sicker than women, even in the background of men have more infections than women. Of the infections, men are sicker because more of the infected people are male. Next pie chart simply says what Marcy said before. The inpatient versus emergency room ratio, the majority of our patients end up going home. Only 40% are admitted, and of those, only a small percentage, I said 15, it's actually 18%, end up in the intensive care unit. I want to focus on the age of those folks who died. And again, if you look at the numbers below the graph, you'll see they add up to 20. Notice that the vast majority are people over 60. Notice on the left-hand side, 0 patients under 20 have died at home. Well, it's easier to say, since we're not a pediatric hospital, of course that would be the case. That said, 0 patients in California under the age of 20 have died from COVID. And nationally, in the entire United States, less than 40, in the mid-30s, nationally, only mid-34 or 5 patients throughout the entire United States under 20 have died from COVID. Just normalizing that, the flu disproportionately compared to this kills, this year the flu killed 120 children under 20, and in 2018, almost 600 children were killed by the flu versus, again, the 30 in the entire United States that have so far succumbed to COVID. The inpatient length of stay for our patients at HOAG has drifted towards the left, the smaller numbers. There are some clear outliers that have been with us for some time, but increasingly as we've learned to treat these patients better, less need for respirators, better treatments, including the research treatments I'm about to discuss with you, that length of stay is shortening. So we are dropping down in terms of the number of patients at HOAG on a given day as we speak. As I mentioned, we've dropped down from a peak of about 60, a little over 65 or so, about 2 weeks ago with reopening. We're down to 27 at HOAG Newport Beach today and 30, I think it was 34 total. So about half of where we were 2 weeks ago hospitalized at HOAG. Now, this is the real problem. And it's interesting, the state of California did not even count flu deaths in people over 65 2 years ago during the pandemic, the flu pandemic. We are counting every death, and we see now that the vast majority of deaths, not the vast majority, the majority of deaths are coming from nursing homes. And then add in the workers there. We test now everybody by mandate in nursing homes whenever a single person tests positive. The combination of the green line, which is the staff, and the patients, the blue line, adds up to the red line in terms of COVID positive patients in Orange County in aggregate living facilities. Next slide, please. This is a very high-risk population. People in nursing homes have many underlying conditions. Many of them will have conditions that will lead to their passing in the nursing home. Congregate living, the same thing. They're obviously congregated, so living closely together in the same large household, which is where we know from data the infection spreads most easily. China studies of 300 municipalities showed that the most common place for spreading the virus to numerous people is in a household with multiple people living in a household, closed environment, poor ventilation contributing to it. 70% of those 300 municipality traced infections came from households. About 29% came from mass transit, like buses and airplanes and subways, and only 1 or 2% could be traced to an outdoor environment. So congregate living settings clearly predisposed to spread of infection. They unfortunately have a variation in prevention of infection standards. Now, there are lots of skilled nursing facilities throughout California, very many in Orange County. We at HOAG'S select carefully the SNFs we refer our patients to, although we have to give them a list. We provide grades to our patients. We have a grading system for the skilled nursing facilities we work with, and we integrate with the preferred ones to help develop, train, and support infection prevention programs in those skilled nursing facilities. And that is clearly not just the case for reducing the risk of COVID, but reducing catheter-related infections, reducing pneumonias, reducing sepsis. So we've been very proactive, thanks to Grace Lazinski and the hospitalist team, our quality, and Phil Robinson, going out and actually populating, interfacing with those skilled nursing facilities. Finally, I want to focus on the one thing that I really should be talking about in my swim lane, and that is our research and our experience with clinical trials. The previous slides were simply to give you the background. I'm proud to say that one of the silver linings of COVID, if there can be a silver lining, is that it has transformed our research team, which consists of almost 20 people now, research coordinators, administrative data gathering people, finance people that have to live in a very rigorous and regulated climate of how research is conducted. It has transformed that team into a world-class research organization, straining at the seams in terms of the previous location and numbers of people to deal with the research projects I'm about to show you. I was very proud, and with Phil Robinson, when we got the first remdesivir trial at HOAG, and we have a relationship with some research folks around cancer at USC. They did not have a remdesivir trial when this pandemic started. Our research trials have focused on remdesivir, which has now been proven effective, on convalescent plasma, which is a way of delivering acquired immunity without a vaccine, meaning vaccine produces antibodies. People who have recovered from COVID have antibodies in their serum, so we can provide them, the sick folks, the really sick folks, with antibodies by taking convalescent plasma that has these antibodies from the people who had been infected in the past, and with donation regimen, very simply like that of donating blood, provide life-saving, potentially life-saving, we don't know the results of the trial yet, but potentially life-saving antibodies to people who need them. We also have embarked on one of the country's very few antibody testing trials in our hospital workforce. Everyone from our infection prevention environmental team that help clean patient rooms and our surfaces in the emergency room and throughout, up through our nutrition staff that deliver the food, to our nurses and our doctors. We have tested almost 4,000 of our healthcare workforce, and the Orange County Health Agency was so intrigued by our approach to this, being it one of the first in the country to do so, that they came to us and partnered with us on testing not just our workforce, but the first responders, firemen and police force, and we're conducting those tests as we speak. But the first wave of those tests, we're doing them now, 8 weeks later, and then 6 months from now to see how long antibodies in the workforce last. And I'm anxiously awaiting our presentation of this data online. We've submitted it to a journal, and there's a way of preempting the journal publication, because it takes a month or so, by publishing the results online. That should happen momentarily. I can tell you, surprisingly to some, that because of how well Marcy and her team prepared our workforce, the education, the personal protective equipment, the masking and hand hygiene, and social distancing lessons we've taught our workforce, that our hospital care workforce has approximately 1/4 the prevalence of antibodies that exist in the general community, meaning our workforce has been exposed only 25% as much as the general community around HOAG facilities to the virus. That sounds bad. Oh my gosh, they don't have antibodies. They may get infected in the future. But we're also learning that there's another type of immunity at play. Very recent publications based on T cells. This is an innate immunity that prevents infection based on memory cells. The T cells are memory cells that remember prior infections And the very recent research suggests they remember infections from similar coronaviruses to the new coronavirus, and there's some cross-reactivity. So that adds to our dilemmas, and we're still hypothesizing, but clearly the impact of safety education and having a very safe hospital environment means that our workforce has only been exposed to this virus over the past 4 months, 1/4 as much as the rest of the community. So that's the bottom line on the antibody trial that, again, is about to be published. The first tranche is about to be published. And most excitedly, I can tell you that we're, we've already started the preliminaries of 2 vaccine trials at HOAG. That's going to be the most exciting part because everyone's waiting for a vaccine, which reminds me to remind you all, we currently have a vaccine for the flu. The flu season is coming up. Only 50% of our community and nationwide take the flu vaccine. Please, 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 make sure you get the flu vaccine this year, because should I be wrong, and should this virus continue to not go down as we're hoping, the combination of having patients come to the hospital both with COVID and the flu this winter is a troublesome one. So please, if you can, get your flu vaccines, and hopefully we'll have COVID vaccine by December. I know we will by December. Some of 2 recent trials have just come out showing superb results for 2 leading vaccine trials, one from Oxford and one from here in the US. This is just a list of the trials that we've completed. You'll see 3 remdesivir trials highlighted there in bold, and the convalescent plasma trial that we're part of along with the Mayo Clinic. They're the lead institution in that trial. We're one of the other facilities. Here are an additional 10 trials we could take on, and we'll take on a few of these, but we really need help to bolster our already robust research team and a little additional help with facilities. We can take on a few more of these. This is amazing. I can tell you, being an adjunct professor at Stanford, they don't have this many trials around COVID. And the reason is each department is its own little fiefdom, whereas at home we're unified. We can be much more nimble. The various pharmaceutical companies see that we can enroll patients much more efficiently and equally carefully to the universities. So they are now seeking us out to take on these trials because they want these patients enrolled as quickly as possible. They know HOAG can do it even better than some of the universities. I think I'm turning it over to Marcy here. Thank you so much. Be happy to answer questions later on. Marcy.
Thanks, Dr. Beasy. So next I'm going to be walking through what we have done to make sure that when you visit HOAG that it's a safe environment. We're also going to be talking about the capacity planning that we've done and some work around our supply inventory, our community partnerships and support, which is critical to fighting this. We're all in this together. And then talking about a safe provision of care. So I can tell you, HOAG's facilities are safe and well prepared. I actually thought, you know what, I'm going to be a secret shopper and make my appointments for my checkup, get my mammogram and my annual checkup. And I was impressed with the work that the team has done. We have sanitizing techs throughout HOAG every single day, wiping down surfaces, making sure that all of the surfaces that are touched on a high touch basis and high volume areas are regularly being sanitized throughout the day. We have options in our HOAG Urgent Care where you can go online at hoagurgentcare.com and hold your place in line. And actually, you can call or text when you arrive. You don't have to get out of your car. And if you do need to be seen and come in the building, you go right into the exam room. So we're really happy that the team has instituted that. If you do happen to come to the hospital, I just want to make it a point of saying that not only in our emergency room, but up on the nursing units, we have what has been called cohort units. So you are not going to be on a floor. If you're not in the hospital for COVID, you will not be on a floor where there are COVID patients. That's the whole purpose of cohorting the active COVID patients. So even in the emergency room, those patients are cohorted in a special area where we make sure we protect them and we protect the rest of our caregivers and the public. In addition to that, we are making sure that we space out appointment times, that we are cleaning the equipment vigorously in between appointments, and just constantly reevaluating our practices to make sure that patients that are accessing care are getting it in a safe way. And one of the real great outcomes of this pandemic has been the rapid pace of innovation. And so we launched our telehealth platform at HOAG, what would typically have taken months, I have to say, took just a matter of weeks before we got all of HOAG Medical Group and HOAG Urgent Care and even our emergency room physicians up on the telehealth platform. So we're really, really proud of that work. I also encourage you, to be honest with you, I didn't even know HOAG had a YouTube channel until someone said, hey, go online and watch HOAG's YouTube video of how we've been cleaning the operating rooms and how HOAG Medical Group and the team and the urgent care folks are all the safe practices that they've implemented since COVID. And so I encourage you to kind of get that behind the scenes view and go on HOAG's YouTube channel. You can look at what to expect during your visit. As you can imagine, COVID-19 patients can become very complex very quickly. And so when they are discharged from the hospital or discharged home from the emergency room, at times they need special navigation. So at HOAG, we have HOAG dedicated COVID-19 navigators that have checklists that they go through for either home monitoring or partnering with our community care providers, making sure that patients have all of the resources and coordinated resources that they need to make sure that they don't end up back at HOAG. And we have been very successful with this program and partnering with Expert Stewardship, which I just want to mention because our partnership with Expert Stewardship and our skilled nursing facilities and our home health agencies and our nursing home providers has been really critical. We figured out quickly on that if we took resources and got them at the point of care in the nursing homes, and we made sure that they were following safe practices, they were following right hand washing, that they had the right PPE, and that they were really suited to combat COVID-19 in these nursing homes, that we wouldn't end up seeing these patients at HOAG. So Expert Stewardship is a company that we and both Orange County Healthcare Agency have partnered with to make sure that the county is doing all we can to keep these patients safely in their facilities. So we have been tracking meticulously since February all of our bed capacity, our ventilator capacity, and our supplies and PPE. And we quickly figured out in February and March that we were not going to be able to rely on our typical supply chain vendors to get those needed supplies at the bedside quickly when we needed them. So Robert Braithwaite, our CEO, said, hey, team, we do not want any disruption and we cannot afford any disruption in our supply chain. So he said, find a couple of warehouses in Costa Mesa and I want you to fill them to the brim with all of the supplies and PPE we need to safely care for our community. Because we thought by having our supply warehouses, actually some of them were in Ontario, we thought, oh, no problem, we can get the trucks, get out to Ontario and get them to HOAG stores quickly. But when truck drivers come down with COVID, that plan doesn't work. So we now have 2 warehouses in Costa Mesa right around the corner from HOAG that we can quickly access those critical supplies, our N95s, our gloves, our gowns. As a matter of fact, many of you I'm sure are aware that when the county called and needed 85,000 N95s and 85,000 gowns to get the county opened, HOAG said, we've got it, we've got you covered. And they pulled up a couple of 18-wheelers to the warehouse, and we were so pleased that HOAG was in a position to do that. But if it wasn't for the philanthropy and our foundation and our gracious and very generous community, giving to the COVID-19 fund through our HOAG Foundation, we would not have been positioned to do that. So talk about being so grateful and in such an incredible community. Each and every day, I tell the team of nurses at the bedside and the doctors in the emergency room, HOAG and our community is a very special place, and we are so, so grateful. So thank you to all of you who have given to our COVID-19 fund. We are putting those funds to use each and every day, and we're so grateful. So part of that, the donations, and part of being in a position to give back, we made sure that all of our first responders, our Orange County Fire Authority and our police and our paramedics, had the supplies that they needed, and our community care providers had the supplies that they needed to care for the community. I'll never forget in the photo there with the bandana on, which I now have him in a mask because I can't afford for him to come down with COVID, is our chaplain, Jeff. And he quickly took face shields and masks out to the Newport Beach and Irvine police departments. And in Newport Beach, the commander said, "Come on, Jeff, we're going to get these face shields and put them in the squad cars now. They need them now." So talk about timing and just being able to give that PPE to the right folks at the right time. And it was also great that we were able to partner with a 3D printing company in Irvine, who in the past have been working with us and printing implants for our orthopedic surgeons that had some complex joint replacement. They were printing up these 3D models of joints, and in some cases our stent grafts for our cardiac work. We called them and said, "Hey, can you folks make us some face shields and some other PPE?" And they did. And to this day, they're still our partners in working with us in fighting this pandemic. So we're so, so grateful for our community partners. Next slide. So here's where we need you to sit up and pay attention. And I'm going to talk about what you can do, because we're in this together, and I'm sure you've heard it all about wear your face covering when you're out in public and social distancing. Make sure you have a minimum of 6 feet between you and other folks, even when you head to the grocery store. I know it's tough when you're headed down the aisles. I don't know about you, but I have a hard time figuring out the arrows, going, oops, I'm not in my normal routine and I'm headed down an aisle and the arrows are headed the wrong way, and trying to make sure that we all do our part. That's important. But, you know, now more than ever, it's so tempting to get together and want to celebrate maybe a graduation, or celebrate, you know, like the 4th of July, or celebrate, you know, have a summer picnic. But please refrain, because we really, really can't afford to lose ground in this fight. And so I'm going to ask, if you start feeling sick or you have any symptoms, please contact your healthcare provider. Reach out to them. Hopefully, if you are symptomatic, it'll be a telephone visit or a video visit. And if it is an office visit, what we do ask is that you call ahead and let us know that you're having symptoms of COVID, so that we can plan for your arrival and protect you and your family and protect our caregivers. So once again, now is not the time to become complacent. I mentioned that to wear a mask is important, and continue to practice that social distancing. If you have had COVID and you are a recovering COVID patient, we ask that you would consider donating plasma, because it does work. We have seen it firsthand. Dr. BZ and I have heard the success stories where plasma, convalescent plasma, does indeed make a difference. Also, some additional resources for you. Download the HOAG Healthy Together app. There's some resources on there for you, believe it or not, which I check all the time to make sure that we've resourced the team. The urgent care wait times are right there on the app. So you can just log on and see if you need care quickly. You can see where one of the 13 locations, where's the quickest time to get in. It's a very, very useful tool. Also, I don't see it up here, but hoag.org/COVID has just an enormous amount of information. I was on there today, And I just can't keep up with how quickly things are changing and recommendations and just lots of resources for the community on that hoag.org/COVID. I also want to just ask if you're looking to stay healthy during the pandemic, go on the Hoag YouTube channel and check out our live stream of classes. There's some great meditation classes on there and health and wellness and healthy cooking classes that the team is doing. So just additional great Hoag COVID-19 resources for the community. I'm going to turn it back over to Dr. BZ, who's going to walk us through the next slide.
Well, thanks, Marcy. I think you've already mentioned the community and what a huge, huge impact the generosity and partnership of this community has had in our response. The donations for our COVID-19 fund have helped to procure critically needed supplies. The fund also helps with financial assistance for whole caregivers and staff. You know, given the numbers we showed you, the percentage of beds that COVID patients have taken, when we were shut down for 2 months, it was pretty lonely on some of our floors. There was relatively few COVID patients and no other patients because we stopped all of our elective procedures. This led to some financial hardships for some of our staff who normally would be busy with work. They're coming back to us now, but still that tail is with them. So financial assistance to their families, more importantly, because a number of their family members lost jobs elsewhere. And so there was a financial strain, as we know many people are feeling throughout our economic strata. And the families that are two-worker families, including those that work at Hoag and have a second worker, they have benefited from the community's generosity to our fund, the COVID-19 fund. And of course, we talked about our clinical trials. I neglected to mention, for instance, that without philanthropic support, we could not have done that serology trial of now almost 4,000, and we're going to go to 6,000 workers, hospital workers, and first responders. That was predominantly, it was entirely actually funded through philanthropy. So the research team is quite strained. We need additional personnel. Phil Robinson has a lot of clinical work to do. Need to get him some assistance with a clinical nurse practitioner to help with the data gathering, et cetera, et cetera. So we have a lot of needs around continuing these trials, both from a direct frontline patient to the back office regulatory aspects of getting all these trials together, keeping the books, gathering the data, meeting the regulatory requirements. So as Hoag has emerged over the past years to be a leader, it has served us well because we really had to go into overdrive in responding to this pandemic situation. And the fact is, we were the first hospital in California and the third in the United States to treat a COVID patient. It's one of the other silver linings is it has really transformed this organization like I haven't seen in the 30 plus years I've been here. We are now on a national stage like we've never been before. And our community partners, our community supporters have made that possible. We could not have done this without this community. The response from people, even restaurants delivering meals to our workers during the worst times, all the way to the major philanthropic gifts that have been donated has been spectacular. Really want to thank you for listening to us today, for considering us as you have in the past, going into the future, and hosting us in this unusual way. Hopefully the next time we have something like this, it can be face-to-face, and the vaccine will have been here, and we will be, I hate the term returning to a new normal. I like to think of evolving to a higher state. We will be evolving to a higher state. Thank you for myself. And thank you, Marcy, for including me in this.
So now's the fun part. We have some fantastic questions that have come in this evening, and I'll take the first one, BZ, because it's an easy one. And then I'm going to give you the tough ones. I'm so glad that I get to facilitate this. So one of the questions that came in: do we expect the flu season this year to be a big deal? And I have to say, today, for those of you who might have read the Wall Street Journal, or for those of you who, we get Becker's every morning in the healthcare world, and I'm cautiously optimistic about the flu season this year because the Southern Hemisphere is basically not experiencing a flu. All of the flu that's coming in there is COVID-19. So we are planning for the worst and hoping for the best, for sure. We are planning for that perfect storm where we have a robust flu season in addition, coupled with COVID-19. But what we're seeing is that all of the precautions with washing your hand, not touching your face, all of that is working to combat the flu. So we're very encouraged. Although I have to just quickly say, so every time I hear or see epidemiologists on CNN or on local news networks saying, you know, don't touch your face, and then they touch their face throughout the whole broadcast, right? So I'm just so self-conscious about that. I think I've touched my face 5 times. It's very difficult. Once you tell yourself not to do it, I've been doing it the whole time. So, okay, BZ, this one's for you. This one came in. Among very ill COVID-19 patients, was there any data gathered as to whether or not these patients had received the current flu vaccine and or Prevagen?
And or what? I missed the last word.
And or Prevagen.
I'm not aware of any data regarding that specific item, but it does remind me to say, despite Marcy's optimism about the flu, please get your flu vaccine just in case.
Right. Of course. Okay, how about this one? I can take this one. Are cotton and homemade masks effective or only N95s? Cotton and homemade masks are effective. As a matter of fact, for those of us in the hospital that are not in clinical, what I call at the bedside jobs every day, like Dr. BZ and myself, we are not wearing medical masks throughout the day. I wear a cloth mask. The foundation team here wears cloth masks. They're saying if there's multiple layers in the mask, that's better. And if you clean them, that's even better. Don't forget to wash your masks that you're wearing. But we are definitely saving the N95s and the medical masks for the frontline caregivers, without a doubt. Okay?
And please move them over your nose, too. I see a lot of people with their nose protruding out above the mask.
That's right. Dr. BZ, here's another one. Why do you think we are seeing a surge in COVID-19 cases here locally? What is contributing to this?
Well, I did mention that. Hopefully, maybe I wasn't clear, but clearly with Memorial Day reopening, remember the timeline. The timeline for infection, actual infection, to when symptoms appear, when they're severe enough, you're going to see at least a 2-week lag. So that takes us to mid-June. With continued disregard for some of the recommendations that were made. Yes, the bars are open, but do you really want to be in a closed place with your inhibitions down, that's poorly ventilated, people not using common sense? That just escalated. That's clearly what contributed to the that curve that I showed you rising after Memorial Day, right? The other thing that's contributing, remember what I said about the number of positive tests is not the same thing as new infections. So given that rise fueled by reopening and then fueled by media reports, look what's happening. Oh my gosh, we're in the beginnings of New York Armageddon. The fear factor and the availability of lots more testing drove a lot of people, like Marcy said, we don't test asymptomatics, but now you can do drive-by testing without any symptoms. And so you will start seeing a surge of new positive tests, but those positive tests in some of those people, we don't know what number, those infections happened up to 57 days ago, but they're being detected now, even though they're no longer relevant from an infection spread perspective, because so much more testing is going on. So the additive effects of the real rise in true infections from reopening and poor behavior is added to by the asymptomatics being tested, driven by the availability and also the fear. So we're detecting a lot more positive cases, not all of which are new infections.
So Dr. BZ, here's another one that just came in. Is the virus at risk of mutating? And if so, will the vaccine be ineffective? That's a great question.
That is a very common question, and a couple of things. This virus does not appear to have mutated significantly, unlike the flu, which mutates season to season. In fact, what Marcy said about the Southern Hemisphere, that's how we designed the flu vaccine. We look down south in the summer when it's their winter, because we know that strain of flu is coming this way, and we design this winter's flu vaccine based on what's happening in the Southern Hemisphere in that strain of virus. That's because it mutates year by year. We don't know if at this point whether this coronavirus will mutate in this as frequently or the same way. It has not so far. You will read articles in the press and in the literature describing slightly different mutations, which allow researchers to trace the virus as a European virus or as a Chinese version of the virus. But in terms of its virulence, the mutations that it takes to change the way it affects us clinically, we haven't seen that with this virus yet, which gives us hope that the vaccine will be against a stable coronavirus. I will tell you that the other thing that was found out just very recently, in particularly the AstraZeneca vaccine that was just reported Monday, was that not only did it induce antibodies, meaning the acquired immunity, but it also induced transformation of T cell innate immunity, the cells that have that memory for viruses. So that vaccine gives me more hope that that vaccine, even though the antibodies may not be totally protected, antibodies get all the press, but it's the T cells that give us the innate immunity that remembers and can turn on the other cells that make antibodies. So I think the vaccine will be effective. I'm an optimist on this, and that it will help not just with antibodies, but with T cell immunity against a relatively stable virus. Remember, the measles virus is so stable, we only need to get one immunization, maybe boosted 20 years later. So that's an example of a very stable virus. The flu is on the other end of the spectrum. We don't quite know where COVID will be, but we so far have not seen a rate of mutation that's scary.
Thanks, Dr. Beasy. I'm going to take this one. I have heard physicians I respect who say that winter is what they are really worried about because of seasonal flu and a shortage of beds, hospital beds. Is that a grave concern for HOAG? And I can say absolutely not with this latest surge, if you will, or mini surge. I mean, to be honest, we just don't know. So impressed with not only our capacity, our planning efforts. We're putting together this robust COVID playbook that has the surge plans in place with additional critical care beds. Not only that, the training that has gone on with our nursing team, making sure that their skill sets are absolutely ready to go for a potential surge into the fall and winter, our equipment planning. Absolutely not. I think HOAG is one of the best, most well-positioned hospitals to handle the fall winter surge if it indeed comes our way. And I think if you were to talk to the physician leaders that are on the front lines, they would feel the same. Let me say, I think, BZ, this is going to be our last question for you. Boy, these are just fantastic questions. If I tested positive and I've recovered and I have antibodies, is it safe to assume that I have immunity?
That is the toughest question of the afternoon.
Right.
So let me give you the party line on that. The party line answer is no, you should continue behaving the way that you have been behaving in the past because we really don't know. And better safe than sorry. An ounce of prevention is worth a pound of something. I forgot what it is, Marcy. But the answer is you can't assume that you're immune for more than a few weeks. We have seen antibodies drop down to relatively low levels 2 months out from their production. And also remember that if you've been infected and have relatively mild symptoms, you may not even have produced antibodies. It takes a level of insult, if you will, or viral load, to be more precise, to actually get the antibodies geared up and produced by our B cell factories, the other type of immune cells. So you can have a relative measure of security, but I would still not act. I would still act responsibly for yourself and also other members of the community.
Okay, one last good one, and I hope you know because you mentioned it in your presentation, but
You said that was the last one.
I know, but then another great one came in. I mean, they're coming in faster than I can even handle. I've got them coming in on my phone and pieces of paper under the door here. So here we go. One more great one. Can Dr. BZ explain the 57-day positive test result that he touched on?
Thank you. So this comes. I just reviewed this. There's a literature, science, if you call it, and I looked up what is the longest rate, or what is the longest time that someone has tested positive after infection for COVID. And the longest reported case in the literature is 57 days. Someone that got infected and initially was quarantined, they kept testing that person. Actually, one of the cruise ship passengers went out to 40-some days. Even so, they kept them quarantined until the new science. Science changes. Unlike politics and stances in politics, science actually, we learn and we change our data and our assumptions. So we've learned over the last 4 months something we didn't know, and that is that one can test positive after an infection. The longest amount of time reported is 57 days. The other thing, the critical thing we've learned, is that from the onset of symptoms, you can test positive for 57 days, but that positive sample, if we put it in a culture and watch to see if it's infectious of cells, there's never been a documented case of a positive sample being actually infectious beyond 8 days from the start of symptoms. So we don't need to quarantine people if they test. We don't even test patients after 9 days because they may test positive, but we know they're no longer infectious and they can be returned, go up to our acute rehab unit, go home without quarantining because they're no longer infectious. If they happen to get tested, they may be positive, but it's irrelevant.
Fantastic. Thank you so much, Dr. BZ. I think we're going to have to wrap it up. Yeah, I think we're going to have to wrap it up there. The questions still keep coming in. We could be here all night, but I just want to thank Shady Canyon. I want to thank Raphael and the team there. I have to say, though, I do miss being there in the clubhouse. It's always such a treat for me to come to Shady Canyon and
invite us back when it's safe.
Yes, please. Thank you all that have stepped up and given to the COVID-19 support fund at HOAG. You need to know, be rest assured that every dollar we are stewarding every single dollar, and it is being put to great use to continue to maintain this community asset as we know and love as HOAG. And don't forget to swing by the clubhouse and get your mask. I love the masks that you guys are getting there. They're my favorite masks. And I'm sure you'll enjoy them. And please stay healthy, be safe, and we look forward to joining you in the next Shady Canyon Speaker Series. Thank you so much.
Marcy will autograph a mask for you if you really ask.
Thank you, BZ.